Hello friends, let us come to the next topic, that is the otosclerosis. Now otosclerosis is a very important topic because it's a favorite topic of the examiner for the MCQs. So a lot of MCQs, they come from this topic of otosclerosis, right? So let's start with otosclerosis. Now what is there in otosclerosis? What is the problem in otosclerosis? Okay, so we have discussed some bits in the previous topics, such as at the time of I taught you impedance audiometry, I said that the stapes foot plate is fixed in otosclerosis, right? As you can see over in this diagram also, stapes foot plate is fixed. But why? Why? You see, in otosclerosis, what happens? The normally occurring enchondral bone in the inner ear. So we studied that the inner ear, the bony labyrinth, is developed from the otic capsule. The otic capsule undergoes ossification by 14 ossification centers. So that type of ossification is known as enchondral ossification, and that type of bone formed is known as enchondral bone. Okay, so in otosclerosis, this enchondral bone starts changing to spongy bone, right? The enchondral bone starts changing to spongy bone. Now this enchondral bone is a very organized bone, whereas the spongy bone is an unorganized bone. Okay, so now this change takes place at a place which is known as fistula antifenestrum. Anti means anterior to fenestrum, fenestra vestibuli. So this place is just anterior to oval window. Okay, so that is the place which is the most common site for otosclerosis, right? So what happens over here? Over here there is formation of spongy bone, which is an unorganized bone, as you can see over here. So what will this spongy bone do? It will grow. So it grows and it starts engulfing the stapes. As you can see over here, it has started to engulf the stapes. Okay, and it will keep on engulfing the stapes and it will fix the stapes foot plate. All right, so as you can see over here, now the stapes is not able to move at all. Okay, so this spongy bone leads to fixation of stapes foot plate. Somebody asks you, what is the most common location for stapes foot plate fixation? Okay, so stapes foot plate fixation, you can see that this disease starts just anterior to oval window. So most common site for stapes foot plate fixation is of course the anterior 1/3 of the foot plate. Okay, anterior 1/3 of the foot plate, or you can even say anterior crura. Okay, anterior 1/3 of foot plate or anterior crura, right? All right, now how will this patient present to us? Now this disease is generally seen in females. The female to male ratio is 2:1, all right? So it's more common in females around 20 to 30 years age group. The incidence is more during pregnancy. So remember, the incidence is more during pregnancy, very important, okay? And then it is an autosomal dominant disease. Autosomal dominant disease, 50% of patients, they come with positive family history, right? 50% of the patients, they come with positive family history. Then this is a bilateral disease. Patient has problem in both the ears. Which problem? The patient comes to you with problem of conductive hearing loss. Okay, of course the stapes foot plate is fixed, so the sound from the middle ear is not able to go to the inner ear. So patient has hearing loss in both the ears. So let's say we have a female over here, okay, 25-year-old female. All right, a 25-year-old female recently pregnant, okay, or recently gave birth to a child, presents to you with bilateral decrease in hearing. You see, these kind of questions you get in your exam. Bilateral decrease in hearing, recent pregnancy, 25-year female. So all these things are hinting towards otosclerosis. What else can the examiner give you? She gives a similar history in her elder sister or her mother. Okay, so that means Positive family history is also there. Okay, now other than this, can the patient can have some other problem? Yes, the patient complains of paracusis villi. Now, what is the meaning of paracusis villi? Paracusis villi means that the patient hears better in a noisy environment. Okay, so patient is not able to hear when she is at home, but she is able to hear everything when she goes to the market. So she hears better in a noisier environment. Why? You see, the patient is having bilateral conductive hearing loss. All right. So of course, when you try to speak to her, she is not able to hear. But when you go to a noisy environment, what happens? In a noisy environment, everybody tries to speak above the noise so that the other person is able to hear. Only when we speak above the ambient noise, the other person will be able to hear. So because everybody is practically shouting, the patient is able to hear it better. She is not able to hear the noise because she is having hearing loss, conductive hearing loss in both the ears. Okay, but she is able to hear if somebody shouts more than the intensity of the noise. So her hearing improves in a noisy environment. Right? This condition is known as paracusis villi. Okay, now remember, this is a autosomal dominant disease. What is it? Autosomal dominant disease. So it is also associated or seen in a syndrome that's known as van der Hoof syndrome. Okay, what does van der Hoof syndrome consist of? Van der Hoof syndrome consists of otosclerosis, osteogenesis imperfecta, and blue sclera. Okay, three things: otosclerosis, osteogenesis imperfecta, and blue sclera. Okay, now how will this patient present? We have seen the presentation. The patient presentation is bilateral decrease in hearing. Okay, now what will you find on examination? You see, patient external ear, pinna, EAC, tympanic membrane, they are all normal. The problem is in the stapes foot plate. Okay, so what will you find on examination? On examination, when you see, you will see that the tympanic membrane is normal. Okay, that is the usual cases. But rarely, sometimes, what do you find? You find that this tympanic membrane has a flamingo pink color. Okay, this flamingo pink color tympanic membrane is known as Schwartz sign. Right? Okay, so this is a flamingo pink color. Now this flamingo pink has been taken from the bird flamingo. Okay, so that's the flamingo bird, and this has a pink color. So this particular flamingo pink color is seen on the tympanic membrane, known as Schwartz sign. Okay, now why is this Schwartz sign seen? You see, this Schwartz sign is seen when the enchondral bone is changing to spongy bone. Okay, so that means this is seen in the early or the active phase of disease when this change is happening. Okay, so what happens at this time when this change is happening? There is increased blood flow. There is increase in blood flow, there is increased vascularity to the stapes foot plate or the area around the stapes foot plate where the otosclerotic foci is present. So therefore, this area shines as flamingo pink color on the tympanic membrane. Okay, now this early or active phase of disease is also known as otospongiosis. Okay, so spongiform formation, otospongiosis is happening in this phase. Right? Okay, so let's say you examined, you found that the tympanic membrane was normal. So how will you confirm? What investigation will you do? Number one, the patient has presented to you with hearing loss. Okay, so what will you do? You will do pure tone audiometry. Okay, right? So you will do pure tone audiometry in this patient. Now, let's see over here. What do you find in pure tone audiometry? This is a conductive hearing loss. So, of course, you will find that the patient has AB gap. Okay, you can see over here, that's the bone conduction, and this is the air conduction, and you see the patient has a air bone gap, AB gap. Okay, now let's revise something about the AB gap. So let's talk about some diseases and the AB gap in them. So number one, we talked about the serous otitis media. I told you in serous otitis media, the AB gap is usually 25 to 30 decibels. Okay, so now in chronic otitis media, tympanic membrane perforation. So I told you the AB gap will be 10 to 40 decibels. That depends upon the size and the site of perforation. Okay, now if this tympanic membrane perforation is associated with ossicular discontinuity, okay, if there is ossicular discontinuity also seen, then this conductive hearing loss will be at least 45 decibels, right? Okay, now let's say if the tympanic membrane is intact, you repair this tympanic membrane, or let's say there is a trauma, the tympanic membrane remains intact, but there is a ossicular discontinuity. So I've already explained to you that now the tympanic membrane acts as a obstruction. Okay, so therefore the hearing loss is more, it is 54 decibels. And what about otosclerosis? Okay, how much conductive hearing loss can be there in otosclerosis? Now in otosclerosis, the conductive hearing loss can be up to 60 decibels. Up to how much? 60 decibels. Okay, 60 decibels is the maximum possible conductive hearing loss. Okay, it is the maximum possible conductive hearing loss, and this is seen in case of otosclerosis. You see over here how much conductive hearing loss? 0 to 60. So you can see up to 60 decibels of conductive hearing loss can be seen. This is the maximum. You cannot see more than that. Now, where do we see this 60 decibels hearing loss in otosclerosis? When the stapes footplate is completely fixed. In those patients, you will have 60 decibels conductive hearing loss. Now remember over here, when you go to a Nike or a Reebok showroom and you see outside on the door, there is 60% sale. Okay, so you are very happy, you go inside. When you ask for the commodity, they say it is only 15%, 20% discount. You are disappointed. Then the salesman will tell you, sir, it is up to 60%. Okay, so same way I said, it is up to 60 decibels. That means not all patients will have 60 decibel hearing loss. Some will have 20, some will have 25, some will have 30, some will have 40. Now those patients which have complete stapes footplate fixation, they will have 60 decibels hearing loss. Okay, but 60 is the maximum possible conductive hearing loss, and it is seen in otosclerosis. Am I right? Okay, so please remember, the otosclerosis will show you maximum possible conductive hearing loss of 60 decibels. Okay, anything else that we see? Yes, we see a dip at 2000 hertz of bone conduction. Okay, this dip at 2000 hertz of bone conduction is known as Gerhardt's notch. Now there are three things you should know about this notch. What are three things? Number one, this is a dip in bone conduction. As I taught you earlier, we see the dip only in the bone conduction. Okay, so this is a dip in bone conduction. Okay, remember, this is a disease of air conduction, yet we have the dip only in bone conduction. Okay, the dip is seen at 2000 hertz. Okay, that's the second thing you have to remember. The dip is seen as at 2000 hertz. The third thing you have to remember, I've already taught you that a similar dip at 4000 hertz is seen in noise-induced hearing loss. Okay, noise-induced hearing loss is a type of sensorineural hearing loss, and this is a type of conductive hearing loss. Okay, now these are the three things you have to remember. Okay, as I told you earlier, dip has to be seen only in bone conduction. And before seeing the dip, you must first identify what type of hearing loss it is, whether it is a sensorineural hearing loss or it is a conductive hearing loss. Never run after the dip. If you run after the dip, you are likely to make mistake. Okay. Now sometimes the students ask me, sir, this is a disease of air conduction. Why do we have this dip in bone conduction? Why do we have the Carhart's notch? Okay, so let's understand why do we have the Carhart's notch. You can see over here, I have made a rough sketch for the external ear, middle ear, and the cochlea. Now a tuning fork test is being done. So let's say we have placed the tuning fork on the mastoid process. So what will happen? We give it, the bone take the vibration and transfers it to the cochlea. Okay, so that's our bone conduction. Is it? Okay, is it our bone conduction? No, this is not our complete bone conduction. This is only one part of bone conduction where the sound is directly traveling across the bone and going to the cochlea. Other than this, the sound will also make the vibration or movement of the ossicles. You see, ossicles are suspended in the middle ear. So when you vibrate the bone, now what will happen? The bone is vibrating. So the ossicles which are hanging, they will move. There will be a relative motion. Okay, when you move this, again there will be relative motion. And that will lead to some transfer of sound to the cochlea. Okay, and the third will be, it will vibrate because of the vibration of the bone, there will be relative motion between the bone and the air in the EAC. And that will move the tympanic membrane. Okay, so remember, the bone conduction does not happen by one way. It reaches the cochlea by three ways. Number one, directly. Number two, through the middle ear ossicles. And number three, through the air in the EAC. So these are the three ways the bone conduction reaches the inner ear. Okay, now what happens? Suppose the middle ear ossicles are not working. The chain is broken, or let's say the stapes is fixed. So now we have a phenomena that's known as Carhart's effect. Okay, so what happens in Carhart's effect? You see, the direct transfer to the cochlea will happen, but the one that was going to the ossicles or to the in the air in the EAC, now this is not happening. You see, this is not happening. Okay, and the resonating frequency over here, which is most commonly affected, that is 2000 hertz. Okay, so the Carhart's notch is maximum at 2000 hertz. Okay, this notch is therefore seen at 2000 hertz. The Carhart's notch therefore is seen at 2000 hertz. So that means, will this notch be seen in other cases of conductive hearing loss? Suppose we have a ossicular chain discontinuity. Will it be seen over there also? Yes. The Carhart's notch, again, this effect, Carhart's effect, was first found in patients of otosclerosis. The Carhart's notch was first seen in otosclerosis. So it has also become associated with otosclerosis. We always relate this to otosclerosis, but Carhart's notch is not just seen in otosclerosis, it can also be seen in other conductive hearing loss patients also. Okay, other reasons for it. It's not limited just to the otosclerosis. Right? Okay, so that was your pure audiometry. Another investigation that you can do? Yes, you can do impedance audiometry. So this also we studied earlier, just revising. Normal curve is A curve. What do you see in otosclerosis? S. Remember, S for small curve, S for stiffness, and S for AS curve. Okay, so you see for the AS curve, S for sclerosis, otosclerosis, tympanosclerosis, you see the AS curve. Okay, now impedance audiometry consists of two things. Number one is tympanometry. So what I just showed you was the tympanometry curve, the AS curve, and along with that we have stapedial reflex testing. So now what will happen to the stapedial reflex testing? You see, the stapedial reflex, stapes is fixed. It is not moving. So when the stapedius contract, there will be no movement. Okay, the stapedius cannot even contract because the stapes is fixed. So the stapedial reflex will be negative. Okay, so tympanometry shows AS curve and the stapedial reflex is negative. Together, you know, these are known as impedance audiometry. So with this, you can confirm that the patient has otosclerosis, the stapes is fixed. Okay, so now you have confirmed the case of otosclerosis. What treatment will you do for this patient? The current treatment of choice for these patients is laser stepidotomy. This is the current treatment of choice. So what we do in this condition? In this condition, you see over here, in this condition, the first thing that I am doing is you have the laser beam, and with this you cut the stapedius muscle. So you see the stapedius muscle is cut, then you cut and remove the stapes suprastructures. So you are not touching the foot plate. Right now you cut and remove the stapes suprastructure. So I am cutting the posterior crura and the anterior crura, and you can see all that has been removed. Okay, so now what we do is we make a hole in the stapes foot plate. So stepidotomy, dotomy means making a hole. So now we have made a hole in the stapes foot plate, right? And now what we do is we place in a stapes piston. Okay, so this is a stapes piston. Now this is placed in this foot plate, right? So this lower part will go in the foot plate, and this upper part will be hanged from the long process of incus, like this. Okay, so like this you hang from the incus to the stapes foot plate, you hang the piston, and this piston, this will go inside the scala vestibuli, inner ear, and it will move the fluid when the incus moves, right? So now what you have to do is you just put some soft tissue around this opening so as to seal this opening. Okay, and now the piston will move in and down, and it will move the fluid whenever the sound is given. Okay, so this is your laser stepidotomy. This is the current treatment of choice. Earlier, before doing the laser stepidotomy, people used to do stepidectomy. Okay, so what was done in stepidectomy? In stepidectomy, the whole stapes foot plate was removed. Okay, so the whole stapes foot plate was removed, and then they will place a graft. On this graft, they will place the stapes piston. So that surgery also had very good results. Okay, the hearing was very nicely improved. But the problem with stepidectomy is that when you are trying to remove the stapes, sometimes the resinous membrane is adherent to the stapes foot plate from inside. So when you're trying to remove the stapes foot plate, now you don't know that the resinous membrane is adherent. So when you try to remove it, you may cause a tear, you may cause a damage inside the inner ear. Okay, and when you do that, patient will have sensory neural hearing loss. So you see, patient came to you with conductive hearing loss, wanted an improvement in that, and now she has got sensory neural hearing loss. Okay, so of course, stapidectomy is not done nowadays. Okay, it is done in rare, some indicated cases. In most cases, we do laser stepidotomy, which is the treatment of choice. Okay, remember, I also taught you that even before stapidectomy, we had a surgery which is known as fenestration operation. Okay, type 5 tympanoplasty. So you have watched my videos. Okay, you must have seen type 5 tympanoplasty or fenestration operation. Now, what is done in type 5 tympanoplasty or fenestration operation? You see, the earlier thought was that the stapes is fixed. So only one window is left, that is round window. So sound needs two windows to move. So the thought was make another window. And how was another window made? A fistula was made on the lateral semicircular canal, which was just covered with the graft. Okay, so that the fluid has two places to move in and out. Alright, but that operation has now become obsolete. We no longer do the fenestration operation or the type 5 tympanoplasty. Okay, now let's watch this video on laser stepidotomy. Okay, so we can see over here in this, it will be just the revision of what we have just seen in the diagrams. So this is the stapes. You can see the stapes is fixed. So what we are going to do is we are going to remove the stapes. So you see over here that this stapes is being removed. You see, this stapes has been removed. Okay, so now you can see the stapes is gone. So now what is done now? The stapes foot plate is there over here. So you take a laser, you mark a beam, and you create a hole on the foot plate. Right? So you make a hole. You can see over here with this beam, if a hole has been made in the foot plate. Right? Okay. Now what I'm trying to do, I'm trying to place a stapes piston inside. Okay, so we can see over here, this piston will go like this. A part will hang on the incus long process and the other part will go into the stapes footplate hole. So you see, this is the piston. Okay, a part is there in the footplate, a part has been hanged on the long process of incus. Right? Okay, so now this has been placed gently over here like this, and you can see the part going in. Now I am sealing the surrounding of the stapes piston, which is going into the hole made in the stapes footplate. Right? Okay, and after that I repose it back. I bring back the tympanic membrane and the ESC skin. So tympanomeatal flap is brought back, and you can see that when the tympanic membrane vibrates, that moves the malleus incus, and this movement is gone to the inner ear through the stapes piston. Okay, so this is how we do a laser stepidotomy. All right. Okay, now you can see in this photograph, this is a stapes piston. This is another type of stapes piston. This is the most commonly used stapes piston in India. Okay, this is a Teflon piston. Okay, you can use Teflon piston, you can use titanium piston, you can even use hybrid pistons. So there are different kind of pistons. You can use a nitinol piston, alloy, that's an alloy piston. So you can use different kinds of piston. Okay, the idea or the basic principle remains the same. So this is a Teflon piston, and why I am showing you this photograph particularly, because this is asked in the exam. It's an exam photograph. Identify the implant. So you can see that this piston is hanging from the incus long process to the footplate. So a hole has been made in the footplate, and there it moves the perilymph in the scala vestibuli. Okay, so you must be able to identify this stapes piston if this diagram is given in your exams. Okay, so now before we finish this topic of otosclerosis, let us look at a few exam questions which were asked recently. Now, a patient hears better in noise. The diagnosis is, it is what we just discussed, it is paracusis willisii. So it is paracusis. Okay, remember paracusis willisii. So paracusis, it is not hypercusis. Okay, it is paracusis, paracusis willisii. Now, next question, Schwartz sign is seen in. So that discuss this straightforward question. Schwartz signs, flamingo pink color tympanic membrane, that is of course seen in otosclerosis. Why do we see this? This is because the enchondral bone is changing to spongy bone, phase of otospongiosis. Okay, next, Carhart's notch in audiometry is seen in. You see, Carhart's notch can be seen in a lot of conditions. As I told you, it can be seen in ossicular discontinuity, any other cause where there is conductive hearing loss. But it has been associated with otosclerosis. So if you find otosclerosis in your options, that is the answer you have to mark. Okay, so because we usually relate it with otosclerosis only, it was first discovered there. Okay, so remember, mark the answer as otosclerosis. Okay, next question, we have a 35-year-old female patient. So you see, 35-year-old female patient presents with hearing loss with improvement in noisy environment. All right, so they have given us a female patient, they have given us a hearing loss that improves. There is paracusis willisii. On examination, Renes is negative, of course, and Weber's is centralized. Okay, so Weber's is in the center, that means patient may be having bilateral hearing loss. Renes is negative. Following is the audiometry report. So you see, it's a typical audiometry report. There is a AV gap, there is a Carhart's notch in the bone conduction at 2000 Hertz. So the typical history of paracusis willisii, it's a female patient. Okay, the Renes is negative. The Renes is negative in conductive hearing loss. All right, all of this points towards otosclerosis. Okay, so our answer has to be otosclerosis. Right, let's go and look in this question. Very interesting question that was asked in the AIMS exam few years back. Identify the cause of hearing loss. Okay, so now they have specifically asked the cause of hearing loss. When I was teaching you Puritan audiometry, I taught you the Puritan audiometry is done for two things. Which two things? Number one, the amount of hearing loss, Number two, the type of hearing loss. Very rarely it tells us the cause of hearing loss. Rarely, I said. Okay, so now over here they have done a proton audiometry and they are asking us the cause of hearing loss. Okay, so cause of hearing loss in a 30-year-old pregnant female. So you know the history. Look at the history pointing towards one disease, that is otosclerosis. But you cannot be sure just by history. You have to look in the audiogram also. Whose pivot tone audiogram image given below. Okay, so what is the audiogram report over here? Now this question, this I said it's an interesting question. Why? Because 90% of students, they marked it wrong. Why they marked it wrong? The first thing that they saw was a dip at 4000 hertz. Okay, so they saw that there is a dip over here at 4000 hertz, and therefore they all marked it as noise induced hearing loss. And they said, sir, it was a question of noise induced hearing loss. That's what they told me when they came back. Okay, but you see, look at this question carefully. Look at this audiogram. So I have enlarged the audiogram. You can see the audiogram. What do you notice? This dip at 4000 hertz. Okay, you see this curve. It's a solid line. It's a solid line. The red line, it's a solid line. That means this is the air conduction curve. Okay, and because it's a air conduction curve, the dip is insignificant. Okay, air conduction curves, dips are not to be seen. Right? Okay, you see the air conduction is marked with solid line. Bone conduction we mark with dotted line. We may not even mark the bone conduction sometimes. Okay, now let's look in the bone conduction. Okay, or let's do one thing. Let's separate out the right ear and left ear. So just to explain to you, I'm separating out these. Now all this you have to do during the exam in your brain. Okay, but for you, for explaining, I'm separating them out. So let's look at the right side curves. Okay, these are the right side curves. What you can see over here the air conduction, you can see the bone conduction. Okay, now just to explain to you, let's join the bone conduction. Look over here. What do you notice now? You see that between the air conduction and the bone conduction, there is a AB gap. Okay, see the zero is over here. This is the zero line. All right, this line over here is the zero line, and now there is a AB gap. Okay, I can see at 250 decibels, this AB gap is approximately 45 decibels. Right, so there is a significant AB gap in many frequencies. What else you can see? You see that in the bone conduction, there is a dip at 2000 hertz. Okay, so when we have joined the bone conduction, we can see that there is a dip at 2000 hertz of bone conduction. We call it as Carhart's notch. This dip which is seen in air conduction at 4000 hertz, I told you this is insignificant. Okay, so that was the right side. Let's look at the left side. Now, once again for left side, I will join the bone conduction. Okay, so I'm joining the bone conduction. Once again, you see what do you see again? You see that there is some AB gap. Okay, so we are not sure. Oh no, there is a very small AB gap. So we are not sure the patient is actually complaining of conductive hearing loss or not. Okay, but there is some AB gap. Now the more significant thing over here is, again, there is a dip in bone conduction at 2000 hertz. Okay, so once again, this shows that the patient may be having bilateral otosclerosis. On right side, it is developed more. On left side, it is developed less. So left side, the conductive hearing loss is not much. Okay, you see 0 to 25. Okay, 0 to 25. So only around 25 decibels loss is there. Not much hearing loss, not much conductive hearing loss, but there is a Carhart's notch on left side also. So it shows it's a bilateral Carhart's notch. It is a case of otosclerosis. Right? So the answer to this question was otosclerosis. Now remember, these type of curves, they come in the exam, and these are the realistic findings which you see in a clinical patient. Also, you should be able to join these dots in your brain and see where is the notch. Okay, remember the notch is in the bone conduction curve. We may not have the curve many times. You have to join the curves in your field. Then only you can see the Carhartt's notch. Never go for the notch initially. First, always see what kind of hearing loss it is. As you saw, I first made sure it's a conductive hearing loss by looking at the AV curve. And then I said, okay, there is a notch also. So it's a case of otosclerosis. Okay, so suppose there was a notch, but there was no conductive hearing loss, then we cannot say it's otosclerosis. Okay, right? So this is how you solve the questions of otosclerosis.